Hey everyone, this is Matt Tsai, fourth year med student at LCOM. I built this presentation as a narrated redo of an older presentation I made to give incoming third years a sense of what they can expect during their clerkship year. I hope you find it helpful. I should start with a brief disclaimer. This PowerPoint is not school sponsored, nor am I receiving any academic credit for this. The content of this presentation is drawn solely from my experiences and observations as your typical medical student, surrounded by brilliant classmates. So to start with an overview, clerkship year is divided into 8 rotations. Here I have tried to delineate some of the more unique characteristics of each one. I'll draw your attention to just a couple. Internal medicine is, in my opinion, the most time-intensive rotation because you work 6 days a week on a rotating call schedule. Be prepared to balance your own well-being, a busy hospital service, and a challenging shelf exam. Psychiatry is a favorite in part for its relaxed hours and emphasis on self-care. However, the thing to know is that the shelf exam for this clerkship typically has a higher curve than the others, so keep in mind the threshold for honors will also be higher. The general schedule for rotations is pretty straightforward. You start with orientation, which is usually 1 to 2 days of didactics and clinical skills. There is also usually a travel day allotted for those assigned to further sites, like rural outpatient clinics. Pay attention to the clinical skills sessions during orientation because the SPs will teach you how to do the exams according to the way your CSE is graded. You can imagine how it might be difficult to remember the correct way to do an exam after having worked with several different preceptors for 6 weeks. Some rotations like internal medicine and the outpatient clinics are fairly predictable. You start on service immediately and every day looks the same. Other rotations like pediatrics, OB-GYN, or surgery have separate mini rotations built in. So for example, OB-GYN includes time in the OR on the gyn-oncology service, as well as time on the labor and delivery floor with pregnant patients. Your shelf and CSC are scheduled at the end of each rotation, and depending on your flight schedule, you will either start orientation for the next rotation after a single weekend, or after scheduled vacation time. So keep that in mind, and be proactive in prioritizing your own physical and mental well-being, especially if you only have 2 days to transition. A quick word about grading. The general requirements to pass are to meet the basic clinical competencies, pass the CSE, and score above the 5th percentile on the shelf exam. The general requirements to honors are similar. Meet honors level clinical competencies and score above the 50th percentile on the shelf exam, and pass your CSE on your first attempt. Now, something I wish I had known before starting clerkships was that your grades are more than just a letter on a transcript. They also include written evaluations of your clinical performance, which are summarized in the MSPE or Dean's Letter that is sent to residency programs when you apply. Clinical grades are cited by program directors as one of the critical components in residency application review. Of course, a strong evaluation in your intended specialty can also be a big plus for residency apps. And from class data I have seen, the percentage of honors for each rotation ranges from around 20 to as high as 40-ish%. Okay, let's talk about the shelf, how it's graded, and how to study. Passing, like I said, is determined by score cutoffs set at the national 5th percentile, and honors at the national 50th percentile. These cutoffs change depending on where in your clerkship year you are when you test. So if, for example, a passing score for IM is lower if it is your first rotation than it would be if it was your last. For the majority of clerkships that use an NBME shelf, here are some references I have included from the NBME and another medical school which can give you an idea of cutoff scores that have been used in the past. They are reported quarterly, with the first quarter being defined as the beginning of clerkship. For the remaining clerkships that use an in-house exam, the same principle applies, but you would have to ask the clerkship coordinators for their specific cutoffs. Okay, study plan. This is how I advise students to prepare for STEP and for current shelf exams. By no means the only way, but a strategic one, I think. Aim to incorporate 3 components in your study methods and resources: knowledge acquisition, mnemonic reinforcement, and self-assessment. Knowledge acquisition is where your resource choice is most critical. There are tons of books and videos out there for different clerkships. So on this table, I have included the more common resources I have used or seen others use for each rotation. Those color-coded in red require payment, and the rest are free. I'll speak a little bit about the most popular ones, but feel free to skip this portion of the video if you already have your resources picked out. So in general, people tend to use UpToDate for on-the-spot clinical learning, like when you're waiting for a patient to arrive or you have some downtime in the hospital. Online MedEd is a free and very popular video series that explains in depth many of the clinical problems you will encounter on clerkships. Dr. Emma Holliday is an amazing radiation oncologist in Houston who made 2-hour review sessions for each clerkship, all recorded and free on YouTube. Her videos are great for review, especially the week of the exam. However, her videos are now outdated for the psychiatry shelf, which has been updated to reflect changes in the DSM-5. Case Files is a product for sale that teaches clinical concepts for each rotation through a series of cases. It is not terrifically in-depth, but good for a first read, especially if you are looking for something that isn't too dense. UWorld is by far the most popular resource I have seen for any rotation with an MBME exam. Most people will just go through the question bank and learn from the explanations, but as you progress through and build up a good knowledge base, the questions become more of a self-assessment tool. It would be worth it to purchase an extended subscription, in my opinion, so that you can use the QBank to prepare for both clerkships and Step 2 CK, which is becoming increasingly important as Step 1 shifts to pass-fail. UWorld is especially important for the inpatient IM rotation, since there are tons of questions and you really don't have much time for anything else. In IM, some people also use Pocket Medicine or Step Up to Medicine, which are both fairly dense but comprehensive resources for reference. Not necessary by any means. In neuro, the consensus is that UWorld actually does not cover enough of the material, so some like to use Blueprints for Neuro, which is an easy-to-read summary of high-yield material for the clerkship. You can also consider the AMBOSS question bank, which has a specific neuro section and offers free trials that might be all you need to actually get through the clerkship. For outpatient IM, assuming it is still an in-house exam, just use the textbook they give you. It comes with a question book with plenty of practice. For psych, people use UWorld and often purchase First Aid for Psych, which is a very sweet and short resource. Importantly, make sure any resource you pick for this rotation is up to date and uses the current DSM-5 terminology. For Family Med, the exam is an in-house exam based off of assigned aquifer cases. So focus on those. You can also use the AAFP website if you find it helpful in clinic. In pediatrics, my class had an MBME shelf exam, but since it has since transitioned to an in-house exam, I would say you should definitely focus on whatever resources Dr. Raska has prepared for you. For OB-GYN, it's all about UWorld and learning algorithms. The clerkship also gives you access to a separate OB-GYN question bank called UWise, which some people found helpful after completing UWorld. And lastly, for surgery, people also use mostly UWorld, but some find Pestana's Notes for Surgery to be a great and short reference for all the major topics on the shelf. It's about $30 on Amazon. You could also get D. Virgilio's textbook if you want something in more depth. I will also highlight Surgical Recall in blue, which will not help you at all on the shelf, but is perfect for the questions surgeons will ask you in the OR. Highly recommend to review it for about 5 minutes before each surgery. Not included on here is Boards and Beyond, which I know many use for Step 1. They have released a Step 2 clinical product sometime last year, which might be worth looking into. Okay, so the second part of the study plan I mentioned is mnemonic reinforcement, which is super variable. Basically, just find and commit to a method that helps you remember everything you are cramming in these few weeks. That could be Anki, repeating practice questions, handwriting your own notes, etc. This is really most important for rotations that have different components. To use the example I discussed earlier, you don't want to be learning about gyne oncology and then forget it all while you are on the labor and delivery service right before your OB-GYN exam. The last component is self-assessment. It is absolutely critical to evaluate your own performance routinely to identify your strengths and your weak points. This could just be looking to see how your UWorld average changes every block, but I recommend taking advantage of the NBME practice shelf exams. I think the school gives up to 2 vouchers per rotation, and you can purchase more for $20 each online. Other resources that people use include the pre-test paperback series, which is a paperback question bank, AMBOSS, and the UWise question banks I spoke of earlier. On the week of the exam, continue your studying, including taking an NBME practice shelf if you haven't already. And also remember to prepare for your CSE, which again is usually very similar to the clinical skills you practice during orientation. Make sure you check for updates on your computer so it doesn't crash. And of course, relax the night before, whether that is getting adequate sleep, eating Ben & Jerry's, listening to Green Mountain Medicine podcast, whatever. This slide is a reminder. Do not be afraid to ask for help whenever you need it, because we all need it at some point. Remember that different clerkships can be hard for different people, and clerkship year is by no means easy. You can seek clinical tutoring by emailing Dr. Tim Moynihan, find more clerkship-specific resources by emailing your clerkship director, get mental health support with Dr. Rosen, or if you ever experience or see mistreatment of medical students, you can report that to Dr. Natalie Feldman. Okay, the second half of this recording is dedicated to clinical performance, and this includes general tips and what you can expect on a typical day. I'll also talk a little bit about delivering a strong patient presentation, which I think is one of the main ways medical students are evaluated. So here are some general tips in clinic. You are officially or unofficially evaluated on many factors, including your clinical knowledge, your ability to communicate that knowledge in a patient presentation, and your general engagement with the team in clerkship. Part of preparing for this requires committing to a thought. When you're not 100% sure about a patient's assessment and plan, just put forward your best shot and share your reasoning. Whether or not you're right, this is how we learn in the clinical world, and your evaluators will appreciate you sharing those thoughts rather than staying silent or always saying, "I don't know." At the same time, be proactive in showing your attending or resident what you do know. Not every preceptor is going to identify your strengths immediately, so take the initiative to demonstrate them. This could be as simple as saying, "I read about X, which I thought was relevant to our patient today. Can we talk about it?" Also important is flexibility. As medical students, we tend to be the last to know about schedule changes or clinical decisions, and many times it's inconvenient, but we have to make the best of it. If you're flexible and understanding, your residents will appreciate it. Also make a point to ask for feedback, not just on your last day when you and the attending part ways forever, but earlier than that. Find out your perceived strengths and weaknesses so that you can make corrections while you still have time. And lastly, do not be afraid to ask your fourth-year friends on your team for help. We can give you the inside scoop. The other side of the coin are things you should never do based on real experiences. So never complete tasks you have not been trained to do, particularly in the OR where things are done in a very particular fashion. Now this sounds kind of super jaded, but I have heard it mentioned by several surgical and OB-GYN residents and attendings about medical students, so I'm including it here. If you are in the OR and you want to help, just ask how you can. Don't reach for any tool or device without checking first, even something as simple as turning on a device for the scrub nurse. Secondly, please never steal a learning opportunity from another medical student. Sometimes this happens accidentally, but when someone interrupts your presentation or jumps in and answers a question that was directed to you, it sucks. Let's give everyone their chance to shine. Third, never lie, which sounds like a no-brainer, but this actually happens more often than you might think. Attendings will ask you, did you ask them X? Did you check their pulses, any rashes? And it can be so tempting to say, no rash, or 2+ radial pulses bilaterally, without actually having done it. I have seen residents make that mistake and lose complete credibility with their attending. If you don't know or you didn't ask the question, just be honest and say you will go ask now. The one thing people will undoubtedly count on medical students for is reliability. Never come in sick. Someone came into work sick once with the flu, and the week after, everyone was miserable. If you need the day off because you have a fever and you are vomiting, your team will forgive you. They will be less forgiving if you infect the entire staff. Just let them know as soon as you can as a courtesy. And lastly, don't disrespect the nurses. They work super hard, and we're all on the same team. Okay, let's talk about one approach to outpatient clinic. This applies to family medicine and outpatient IM, as well as the outpatient clinics on OB-GYN, surgery, and peds. The benefit of these clinics overall is that you tend to get more one-on-one time with attendings that you do on inpatient teams. Usually attendings will ask you to see a patient while they see another one to save time. And in my experience, I was often asked to see all the new patients. When you finish the encounter, you present to your attending and then go back into the room to see them together. A pro tip is to log into Epic and read about these patients the day before. You can review their medical history, medications, chief complaint, which would allow you to prepare your clinical approach and differential diagnosis beforehand and sound way smarter when you present. For example, say you have a patient with a chief complaint of cough. You can briefly go on UpToDate, Dynamed, whatever resource you want to use, jot down key questions to ask, physical exams to do, top 3 causes of cough in the United States, and most common tests recommended for workup. When you show up to clinic on your first day, the attending will usually ask you to shadow for at least a few sessions to become familiar with the clinic. This is not a chance to chill. Take advantage of this time to take vigorous notes on the specific questions your preceptor asks and how they counsel their patients, because that's what they will expect you to replicate. Make sure you include all those components when you are conducting the interview. Always conduct both the history and physical exam whenever you see a patient. The exceptions are genital exams, which you should never do alone with a patient, or breast exams, or exams that are too painful to do twice, such as eliciting the Roth-Singer or Murphy signs. When you complete the encounter, take a couple minutes to organize your thoughts before you present, which in my experience can really make all the difference. In terms of note writing, in the outpatient world, your responsibilities will vary by attending. Some will ask you to write the whole note with their template, and others will just want a presentation. So that's outpatient. Let's talk about inpatient. Inpatient services are much more team-based, meaning you tend to have more time with residents and less with attendings. There are 2 ways that you see patients. The first is called admission or consult. So depending on the rotation you are on, you will see a patient for the first time, gather a thorough history, do a thorough physical exam, and then present. Questions you want to consider for these patients include, does this patient need to be admitted to the hospital? What tests do we need to order? What is their diagnosis? And if they stay in the hospital, what needs to happen before they can go home? These are great cases to run by with your residents before you present. The second way you see patients is during your morning pre-rounds for patients that have already been admitted to your team and who you're just checking in on each morning. You then present these patients daily during team rounds, sort of like a quick update on their condition. These encounters are abbreviated, and so your presentations are also much shorter than a full H&P. Most inpatient services will also expect you to write notes on your patients. You'll write a full H&P for admissions and shorter progress notes for the patients you see each day. There are templates for both of these in Epic. Now, for some inpatient rotations like I am, the typical day on the inpatient service starts with sign out. You and your team members will meet the resident night team and obtain any updates for your patients that happened overnight. Other rotations, like surgery, may not expect you to be at sign-out and instead just ask you to begin pre-rounding early in the morning. Pre-rounding is essentially checking in on your patients and doing a mini history and physical exam. That includes asking how they're feeling, about their pain level, whether they're eating and moving, urinating and having bowel movements. You'll also want to listen to their heart and lungs and repeat physical exams that were abnormal on admission to gauge how things are progressing. This is also a chance to check Epic to see updated vitals, labs, and new notes from nursing or consultants. Then you round and present your patients. You'll receive feedback in real time on your assessment and plan, which you can then update in your note. We'll get to presentations in a second. Depending on the service, the rest of your day after rounds is divided into seeing new patients and presenting them to your attending, writing notes, and going to any scheduled teaching sessions. Your team might ask you to help update the discharge summary note, which is a succinct running note that summarizes a patient's hospitalization course. Sometimes your resident will also ask you to stay to observe sign-out when they change shifts with a night resident team. Other times, your residents will dismiss you once your work is done. So, how do we present? A new patient presentation should be organized, concise, and to the point with the SOAP format. That's subjective, objective, assessment, and plan. Start with a one-liner that includes the patient's age, sex, key pertinent medical history, and chief complaint. For example, 55-year-old female with a history of hypertension presenting with acute chest pain. Then report the subjective. What did the patient say? This includes your summary of the HPI, relevant review of systems, past medical and surgical and social history, etc. Next comes objective, as in objective data, starting always with your vitals, and then physical exam findings, and then lab or imaging tests if available. Then there's assessment, which for a new patient is usually just 1 to 2 sentences about your differential diagnoses and reasoning. For inpatients whose diagnoses are known, you would instead briefly talk about their progress to recovery, something like patients now stable and improving on anticoagulation. Your plan, which comes afterwards, is a diagnostic test or treatment you think should be given. Since hospitalized patients usually have more than one problem, you would have a specific plan for each problem. Overall, your presentations should be less than 5 minutes in the outpatient world, longer if it's an inpatient. For known inpatients, as in the patients you pre-round on every morning, your presentations would also be brief and include any updates you heard at sign-out, objective data like daily lab results or imaging, and if relevant, what the nursing staff have recorded for fluids in and out. In other words, how much fluids taken in by mouth, by IV, and how much out by urine and stool. This is an example I wrote up of an outpatient presentation in SOAP format, which you can review. Again, inpatient presentations would include more objective data like lab values and imaging, as well as a summary of the sign-out if applicable. Also notice in the assessment how I am pointing out the research I have done to back up my differential diagnosis. This is going back to being proactive about demonstrating what you know and have learned. Also notice that this is a differential, not just a single diagnosis. If you can, always have at least 2 diagnoses to consider in your assessment. Your CSEs will also require this. An inpatient presentation would have an expanded plan organized by problem. So in this case, problem 1 could be chest pain with the above mentioned plan. Problem 2 might be this patient's chronic and stable peripheral edema with a plan to monitor. And much of this presentation style just takes practice. Okay, wrapping up. These are a few pointers in hindsight which have come to mind during the interview trail. Faculty might offer to write you a letter of recommendation after a rotation. Say yes. This is not binding and doesn't hurt you in any way. Try to keep a personal running list of cases you find interesting and consider writing them up as a clinical vignette presentation, which could potentially lead to publication. And keep a separate list of patients who taught you something or whose lives you touched. These victories will build you up when you're low, and they are also the focus of many common residency interview questions in your near future. And that's all I got. If you made it this far, thanks for watching, and I hope you find it helpful as you enter the clinical world as medical students. Feel free to send me any feedback, good or bad, by email, in person, or on Twitter. I could use some followers. I'll conclude by asking you to remember how far you all have come. You have each put in the work and have the potential to impact the care of your patients in truly incredible ways. Believe that, and look for those opportunities scattered on your rotations. Lastly, lean on the support of your clinical teams, your faculty, your fourth-year student mentors, and each other. You got this. Good luck.